All right, we're going to get started. My name is Andriana Smith. I am the program chair of the MGMA, and we welcome everybody from ACHE Mid-South for joining us today in our joint meeting. We love doing these around things that are going on in our state and local government, and we've got two great panelists with us today, Mary Freeman and Rob Clark. So I'm just going to tell you a little bit about them, then we're going to jump in, get started, and let you guys also ask questions of them. So it's all about legislature today. It's exciting because we're in election year. So we'll listen to them as they talk about things that are currently happening in our state and our federal government around healthcare. So first I'm going to start off with Rob. Rob Clark is currently the Chief Government Affairs Officer at St. Jude. He has progressively had responsibilities in healthcare management since he completed his master's in science in healthcare administration from the University of Memphis. The first part of his career was spent primarily at Baptist Hospital in practice operations. He was recruited in 2002 to join St. Jude, and he is responsible for public policy and government affairs for the institution at the federal, state, and local levels. He also serves as liaison for the St. Jude Comprehensive Cancer Center for state and federal outreach and serves on the Cancer Center's HPV Blue Sky Initiative. Rob currently serves on the Government Relations Steering Committee at the Greater Memphis Chamber of Commerce, amongst other things. He also serves on several boards. For MATA, he's the on the Board of Commissioners and also the Vice Chair of the Memphis River Parks Partnership. Miss Mary Freeman, she serves as the Director of Government Relations for Baptist Memorial Healthcare in Memphis, Tennessee. In her role, Ms. Freeman provides leadership and direction relative to government and legislative matters impacting patient care and business operations. Ms. Freeman entered the private sector after more than 20 years of legislative and policy experience in state government. Prior to joining Baptist, she was chairman of the Tennessee Regulatory Authority, having been jointly appointed by then Governor Phil Bredesen, Lieutenant Governor Ron Ramsey, and the Speaker of the House. She also served as legislative director under Governor Bredesen and as executive assistant to former state Lois D. Berry. Ms. Freeman is active in Memphis, in the Memphis community. She currently serves on the board of directors of the 100 Club of Memphis and CAP Incorporated. She also is a member of the NAACP, League of Women Voters, and Alpha Kappa Alpha Sorority Incorporated. So as you can see, we have two very accomplished speakers today. And then Clint Cummins, who is our executive director of the Memphis Medical Society, will be leading the discussion and moderating. So Clint, I'll hand it off to you.
Thank you, Andriana. Welcome, everybody. I'll give another title of mine today that I rarely get to share, and that's the legislative chairman of the Mid-South MGMA chapter. That's not one I get to say every day, so I'm proud to say that and proud to actually use that title today. So Mary and Rob, thanks for spending your time with us today. I'm looking forward to this discussion, and we're going to jump right into the questions if y'all are okay with that.
Sure.
Good.
To kick us off, what do you all see as the role of government, payers, and providers in improving the social determinants of health, those such as environment, employment, and income, transportation, food, and diet? Rob, you want to go first with that one?
Sure, happy to do that. And just one correction to Andriana's introduction. I graduated grad school as Ole Miss and not Memphis. Although I'm a huge Tiger fan, I was at the game last Saturday. Exciting win for the Tigers, and really appreciate that program. So again, thank you, Clint, Andriana, for inviting me to participate in the panel with MGMA. So to your question, Clint, yeah, social determinants of health, I think is increasingly becoming responsibility of providers, payers, health systems. mean, as we move from a transaction-based healthcare system to an outcomes-based care system, all those things that influence a person's healthcare, a person's well-being, whether it be educational opportunities, economic opportunities, transportation, accessibility to food, all of those things play a role in keeping people healthy, which is ideally how the healthcare system should be incentivized. We're not quite there yet, but we're evolving into that. I mean, I've personally, since I've been in this industry the last 30 years in Memphis, I've seen providers like Baptist, Methodist, St. Francis, the larger ones, become much more involved in issues like public transportation. You see, where some of these large health systems are actively advocating for government and private industry to step up and support, a public transportation system like MATA that helps people get to their jobs, that helps people access healthcare and good, food shopping opportunities. So, I think there's definitely, we're going to see this trend continue, and I think it's a very positive thing for our community.
Mary, anything you want to add?
Yes. So I guess I'll start by just saying what everybody knows, that social determinants are real and there are significant barriers to improving the quality of life, economies, and lowering healthcare costs. The role of all parties, government, payers, and providers are vital to creating real change in healthcare outcomes and lowering cost. The government's role is multifactorial. I see the government as a convener of the providers and payers to design processes and systems to address social determinants, and as a payer for wraparound services. Government should also be building community infrastructure for quality housing, public transportation, and addressing environmental concerns, etc. Now with the payers, I think payers have to look at their reimbursement models and how they partner with providers to improve care coordination and access for their members. As providers like Baptist, we have to continue our paradigm shift from treating illnesses to helping individuals understand and manage their health. This includes partnering with non-traditional organizations to address the needs of individuals in our communities. Now I'll address some of our partnerships. First, I want to mention our Best Health Well-Being program at Baptist. And this, about 4 years ago, Baptist made an investment in managing the health of our employees population by launching a Best Health Well-Being program to help employees better manage their health and in return, hopefully lower the cost of care. Employees must be enrolled in our Blue Cross Blue Shield medical insurance plan to participate. The program offers incentives up to $300 to employees who complete various steps. That includes a required annual wellness visit with their provider, and that visit includes a biometric screening as well as a tobacco screening. And with the tobacco screening, there is an $80 monthly tobacco charge if an employee tests positive. However, the charge can be avoided if they complete one of 2 complimentary tobacco cessation programs. We also, with this program, have to complete a risk assessment questionnaire. There is an app associated with the Best Health Wellbeing program. And all of this is just an effort to help employees work toward a healthier lifestyle. Another program I want to mention is our Baptist Operation Outreach mobile unit, and this mobile unit provides free acute and primary care, disease management support, and prevention information to Memphians without permanent housing. Baptist started providing mobile health care for the homeless in 2003 and officially started Baptist Operation Outreach, a partnership with Christ Community Health Services in 2005. When Baptist Operation Outreach first started, the mobile clinic had about 500 patient encounters. And today, patient encounters are up to 3,000 a year. So we're pretty proud of that and the work that we're doing in that area. Another program that I would mention is the Baptist Making Healthier Communities program that provides healthcare resources to community organizations and church congregations of all faiths that have a vested interest in achieving a healthier community. This program helps remove barriers to medical care and fills the gap for many underserved, underinsured, and uninsured members of the community. And I'll just close with this. As providers, I think we have to continue the work towards and support actions based on our triannual community health needs assessment and implementation plans, and use those results from each assessment to guide community initiatives, engage appropriate partners, and address community need. And I'll stop there. I have some more programs to mention, but I'll stop.
Well, they might come up in some of the other questions. Some of the comments y'all made certainly brought up the issue of access. So can you talk a little bit about what's being done to reduce the uninsured rate and improve coverage? And what do you recommend as far as the policy actions we need to take as payers and providers?
Rob, you want me to go first?
Yeah, you go ahead and get that one.
All right. Okay, so in my opinion, very little is being done. The most significant and hardest policy action regarding the uninsured is expanding coverage. I think we have to accept that insurance coverage isn't about a political party, but about ensuring that people have coverage which affords access to the most appropriate healthcare setting for their urgent and chronic healthcare needs. As it relates to policy actions, one important thing I already mentioned that government could do is expand Medicaid. Currently, Medicaid is designed to provide health insurance for those living below the poverty line. We live in a state that decided not to expand Medicaid. Additionally, Baptist has hospitals in Mississippi, which is another state that has declined to expand Medicaid. And Arkansas has a hybrid plan where they partially expanded Medicaid. But for those states that have expanded or are considering expanding Medicaid, they are also looking at adding work requirements as a condition for receiving Medicaid. In theory, that looks and sounds great. However, in reality, the problem with work requirements on individuals living below the poverty line does not take into consideration the factual reality of their lifestyle. Secondly, I would say the majority of those individuals have children, and with children comes the responsibility of attending to them. If we are to require them to work, 9 times out of 10, the level of employment they will get will be at or barely above the minimum wage. As a result of which, if I am an individual on Medicaid with 1 or more children, I now have to work. That means I now have to place those children in daycare, which also means if I'm living at or below the poverty line, in order for me to get a job, I need to have access to transportation, whether it's public or personal. So while it might sound good to say we need to work I'm sorry. So while it might sound good to say you need to work in order to receive Medicaid, in my opinion, the reality becomes we are just perpetuating the cycle of poverty by putting those types of requirements around conditions to receive that bid.
Rob,
And
anything to add? Oh, I'm sorry, Mary.
I was just going to mention about the payers. As it relates to the payers, I think payers can be more progressive as they look at underwriting policies for the working poor. We have a number of individuals who aren't eligible for Medicaid, which covers those below the poverty level, but we don't have adequate policy and programs out there for them. I think it would behoove the private payers to work together to come up with a program that would address affordable premiums for the working poor.
Great. Yeah, just to a couple points to build off what Mary has very well stated. I mean, obviously, if you want to decrease the uninsured rate, you increase the number of insured people. So universal coverage would take care of that. You know, how you work that out from a dollars and cents standpoint is way above my pay grade, but I think it is interesting to note the politicization of this issue. As Mary has noted, Tennessee is a state that, you know, has lacked the political will to expand Medicaid, which would go a long way to decreasing the number of people on the uninsured rolls. If you look back 2 administrations ago to Governor Bredesen, you know, there was during the recession of 2009, 2010, TennCare made the decision they had to cut people off of their rolls because they didn't have the money in the budget to cover the people that they had added on in prior years. And I think you have a fear among some of the legislators who are still up there that could happen again. And nobody likes cutting people off of a benefit that they've been used to. But I will note that Governor Haslam, you know, did signal a desire to take advantage of the expansion offered under the ACA. The General Assembly did not see, was not on the same page with him, and so that was not expanded. And again, under Governor Lee, just 2 years into his term, has not indicated, you know, any political desire to do that. So it's unfortunate that that healthcare, which is such an important part of everyone's life, everyone needs access to care, has become as politicized as it is. I will note that while you know, expansion of Medicaid is kind of a non-starter in Tennessee, I think there are other ways to help people who are not insured to become insured. And one way is to get a good paying job with a company that does provide health insurance. I mean, obviously, our model of care in the United States is still predominantly employer driven. And so having a good job equals having good insurance. It just goes hand in hand. I will give Governor Haslam credit for starting a couple of initiatives on the education front that were designed to get people into good paying jobs. Tennessee Promise, Drive to 55. These are programs that make it accessible to every Tennessean to get 2 years of college tuition free. And then Drive to 55 is designed once you know, somebody has made that transition from high school graduation to college, to get that to go ahead and graduate from college, to get 55% of the state with a college degree, which will go a long way towards helping us to recruit the types of companies that pay the high paying jobs. So as we noted on the first topic, I mean, everything's interrelated, right? Education, healthcare, economic development, transportation. So again, this is one of these issues that we're not going to solve anytime soon. We have an election coming up in less than 2 weeks. We could see definitely a sea change at the federal level, depending on which way the election goes in terms of the priority of a new administration. So we'll have to wait and see how that plays out.
I'll take a point of personal privilege and just remind everybody to go out there and vote if you haven't yet. All the news suggests that the early vote turnout is good, and I don't think anybody can argue that that's a good thing. So we want to encourage everybody to make sure maybe on your lunch break tomorrow you go and vote if you haven't already. So as Rob mentioned, all of these things are interrelated, and one thing we haven't talked about specifically yet are health plans, and this trend toward high deductible health plans and more patient cost sharing is contributing to this increased focus on price transparency, improved patient cost estimating, and avoiding those surprise or balance bills, as you hear that term said in the news, and then the quality information sharing and a lot of other things. So what are the key policy issues here? What's working, maybe what's not working, and what do we need to be doing in y'all's opinion? Mary, you want to kick us off?
Okay. Okay, so I'll just start by saying that Baptist offers a high deductible plan. We used to provide a 90-10 and an 80-20 plan, but about 5 to 7 years ago, we eliminated the 90-10 and we went with a high deductible plan called the consumer driven plan. We still have the 80-20 plan as an option too. The theory around our high deductible plan, as I understand it, was if the consumers had greater responsibility, would utilization decrease, and would they choose the least expensive provider? Baptist Memorial Healthcare Corporation has a trust called Baptist Memorial Medical Ministries Employee Health and Welfare Trust. And this trust oversees the financial well-being of our Baptist self-insured employee health program. I personally do not believe that the move toward high deductibles has created a focus on price transparency. Rising costs generally have created an issue around price, coupled with the billing practices of hospitals. As most of you are aware, the hospitals have what are known as charges. Hospitals also give discounts off of the charges. If the difference between those two numbers that has created a tremendous amount of confusion, it's the difference between those two numbers that has created a tremendous amount of confusion amongst the patients that we as hospitals provide. In order to address that issue, I believe it is going to require a lot of work, because when individuals raise concerns about surprise billing, they don't know how much a procedure is really going to cost. I know I don't. That is a byproduct of a complicated system. The complicated system is predicated on the fact that the insurance companies allow hospitals to establish charges, which is known as a charge master. And that charge master tells you how much any given procedure is going to cost. From that, there is also negotiation with payers to get a percentage discount off of those published charges. So I believe posting charge masters on the internet adds little value to the consumer. It does nothing to ensure the patient is receiving the price listed on the charge master, because it only serves as the basis for negotiations of the price. That price is typically determined based on the volume of patients anticipated to be received by a hospital, or if it is an indigent or self-insured individual. The charge master becomes the basis for determining what level of discount they will receive. For institutions like Baptist, we have policies in place that allow for a discount based on catastrophic charges, as well as if the person is indigent, they will receive a certain level of discount off of their bill. Another issue when people talk about surprise bills, most of them don't realize in states like Tennessee, hospitals cannot employ certain physicians, such as anesthesiologists, pathologists, radiologists, or emergency department physicians. That is a function of law. What it creates is when you come to a hospital, you get a bill from the hospital. If a pair, and I call it a pair because it's the pathologists, emergency department physicians, anesthesiologists, and radiologists, if one of those physicians treat you, you will also get a bill from each of those physicians or the entity that employs them. So I agree, it does create a lot of confusion. So one thing that can be done to streamline and simplify the process is to eliminate what is known in Tennessee as the prohibition against the corporate practice of medicine. That is a statute that keeps hospitals from being able to employ those physicians, or there could be legislation that would require those physicians to allow the hospital to include their cost as part of the cost of the bill that is presented to the patient. On quality, above all else, I would say above all else, as we move to an era of more emphasis on quality, it would be extremely helpful for the citizens and patient to have a process in place that does in fact focus on quality. So when I say focus on quality, we need to come up with one standard, because right now, every hospital, every physician office or caregiver, they probably all have on their websites that they have been approved by X number of stars by ABC organization. You most likely don't know what ABC organization is. I don't know what ABC organization is, but there needs to be a gold standard. So any hospital that says that they have X stars, those X stars mean the same thing because it was given pursuant to a gold standard that has been established by a reputable organization. Absent that, I think we will forever be playing the shell game around price and quality, in my opinion.
Love that analogy of the shell game. Rob, anything you want to add?
Yeah, I mean, price transparency is such a an interesting topic to try to get our heads around as it pertains to what we've been talking about. And nobody likes surprises, right? Especially when you're paying for something. If I go to a restaurant and I look on the menu and I say, okay, I'm paying X, Y, and Z, and then they bring me the bill and there's some item that said, oh, we used a special oil for your stroganoff, so that's additional $15. I'd have a stroke. So as consumers in this country, again, and we're a consumer-driven economy, we're used to having information. And in the era when everybody has this accessible to them with any number of apps that allows you to go on, if you're buying a house, you go on Yelp. You go on realtor.com, you look at information. We're used to doing that. And so I think there's a huge pent up demand for people in this country to be able to have that information. And I agree 100% with what Mary said. A hospital posting a charge master on their website does nothing to help me as a consumer understand any more than before they posted the charge master. I think the types of things we need to be looking at are you can't separate price from quality, as Mary said. If I'm going to pay $25,000 to Hospital X for a total knee replacement, I want to damn sure make positive that, number one, it's going to be a quality outcome, that they have the systems in place, that they have the ratings that I can look at, that they have the low infection rate, that they have a great rehab team. I mean, that's the sort of thing I'm willing to pay X price if I know I'm getting X quality. And so you can't just publish a bundled price for a total knee or a total hip without publishing the quality outcomes of that team. You know, we've seen in California that, again, they're a bit more progressive on the West Coast in terms of price transparency than the rest of the country. You know, for Medi-Cal, they've been posting flat payments for certain orthopedic procedures, and they've seen that that's driven the cost down. And so, you know, having a good system where you can see price and quality side by side, allowing the consumer to be informed, can help drive down costs in healthcare. I don't think there's any question about that. Combined, like I said, with technology that's even going to be even more sophisticated, with 5G, with AI, you know, with the advent, and we're going to talk about this in just a little bit, of some of the disruptive things we're seeing coming out of COVID. Increased telehealth, increased remote access to care is going to do nothing but enable the consumer. So we have to get our heads around sound policies that helps to affirm the consumer's right to shop for his or her care.
I think those are good points. And, you know, no matter who is ultimately paying for that care, I think COVID has initiated the opportunity for them to really aggressively look at pricing and how things are, you know, structured from that standpoint. And I think that's only going to evolve. So stay tuned, I suppose. Rob, I'm going to stay with you for this first question here. What are the other, you know, key legislative issues that you guys are looking at, and what kinds of things are you promoting right now?
So, you know, let me stay on COVID because, you know, that as a disruptive event in all of our lives, of course, disruption leads to innovation. And so, even though none of us would wish for us to be going through this time, you know, I can definitely see some positive things that are coming out on the innovation side in terms of how we take care of our patients. You know, at St. Jude, we're kind of a unique environment in that almost all of our patients that we care for are immunocompromised because of part of their cancer treatment or even the non-cancer treatments that we deliver. And so we've had to be extremely vigilant in terms of keeping patients, family members, staff healthy so that we don't run the risk of infecting a patient whose immune system is already compromised. So as we talked earlier, St. Jude, you know, has developed our own testing system for staff, and we've had staff much more working remotely than I think, you know, other places. We've looked at increasing telehealth, as many other healthcare providers have. We've found that by treating our patients remotely when it's available to do so, that keeps them from running the risk of coming on campus and risking getting infected. Again, from the policy side, St. Jude really focuses a lot more of our attention on, at least at the federal level, biomedical research, NIH funding, drug development at the FDA. I think as we look at racing to come up with a vaccine for the novel coronavirus, we've seen some substantial changes at the FDA process in terms of their approval of a vaccine. As you probably are all aware, we've got 7 different vaccine candidates running simultaneously clinical trials in order to hopefully get one or two approved to go to market as soon as possible. You've already seen states distributing protocols on how they're going to distribute the vaccine. So this is unheard of in terms of the drug approval process. And so as an institution that really depends on rapid drug development, especially in the pediatric oncology space, this can only be a positive moving forward as we, St. Jude has always, been known for rapid movement of discovery from the laboratory to the bedside. And having the pharmaceutical side of that component play a much more rapid role in therapeutic design is only going to benefit our patients. So, the other thing that from a policy standpoint that COVID has driven for us is we went ahead and made the decision again to try to take care of our patients remotely when possible, to apply for a certificate of need for our own home health agency in the 3 Shelby, Tipton, and Fayette counties. So again, I don't think you would have seen us choose to go down that policy path were it not for this pandemic, but it has driven us to be creative, to find ways where we can take care of our patients, again, in their secure home facility, whether it's an on-campus facility at St. Jude or whether it's their own private facility. And so I think those are things that we're definitely focused on at St. Jude.
St. Jude's always fascinating. Mary, what kind of things are Baptists looking at right now?
I would ditto a lot of the things that Rob stated. I guess I wanted to kind of focus a little bit on some of the state legislation that we're going to look at in January. I mentioned the corporate practice of medicine, repealing specialist employment prohibition, which is I mentioned earlier, and then the certificate of need legislation has reared its head for the last 3 or 4 years and will again next year in the Tennessee General Assembly with reform and or repeal legislation. And surprise billing, we're hearing that the governor will most likely have a piece of legislation to deal with surprise billing next year. And I think every payers, providers, everybody wants the same thing as far as holding patients harmless. Medicaid expansion, that's still an ongoing priority. We'll see what happens if the Trump administration approves Tennessee's block grant. And then I'm sure there'll be additional telehealth legislation that will need to be looked at next year.
So y'all touched on this a little bit, and this is our final prepared question. So those of you out there that have some questions for the panelists, feel free to start typing them in. Both of you touched a little bit on how COVID's impacting the environment at your institutions, but any other comments you want to add to that on either how it's affecting the institution or what impact it's had on your legislative priorities? Mary, you want to start with that one?
I think, like I said, Rob did a good job of covering a lot of that with regards to the pandemic. I would just mention maybe a federal issue that's going on. We received some funding from the CARES Act in order to the CARES Act allowed for funding to reimburse eligible healthcare providers for eligible healthcare expenses and lost revenues attributable to COVID-19. The law stated that recipients of the fund had to submit reports and documentation to ensure compliance with those payments. So long story short, the Department of Health and Human Services updated their rule, and it currently impacts our hospitals negatively. So that's something that we're really, really focused on at the federal level with regards to the COVID.
Rob, anything else? From your standpoint?
I would say just from a public policy professional standpoint, the biggest challenge that I think Mary and I and our colleagues face with COVID is the inability to travel and get up to Nashville and DC and interact with our elected officials and the staff like we've always been used to. In terms from an advocacy standpoint, I've found that, I don't know about you, Mary, I've found that to be very challenging because it's one thing to have a remote conversation like this, but to me, it's just not the same as being in his or her office and having the opportunity to have an individual conversation with them. And I'll give you a great example. I mentioned that St. Jude's applying for going through the certificate of need application process to get a home health agency. Well, when we made the decision back in March to go ahead and do that, I suggested to our leadership, look, it's going to be at least a 6-month process to get approval through the CON application process. There's already CON legislation to amend the existing law. Let's just go ahead and get an amendment on there that would give St. Jude the opportunity to go ahead and bypass the CON process. And we were able to do that and get that successfully passed in the House. There was opposition in the Senate, and while I was able to talk to the committee member in the Senate on the phone, I wasn't able to convince them to change their vote. I can't help but think if I had been able to visit with them in person, that might have changed the outcome, but we'll never know. So, that's just a frustrating part of the new work environment. And I don't see, at least from St. Jude's standpoint, again, they're going to be very cautious in terms of allowing employees to travel. We're already seeing indication from the Tennessee General Assembly that when they reconvene in January, they're more than likely going to still maintain kind of a remote process where it's going to be very limited in terms of access to the Cordell Hull building, to the Capitol, if you're not a member or a staff person. So we're going to have to continue from a policy standpoint to navigate these uncharted waters.
Yeah, it's an interesting point about those relationships with elected officials, because if you work with them every day, you at least have an established relationship to build on. But if you're looking to build a relationship from scratch, that can be even more difficult.
Yeah, absolutely.
During COVID. So us in the healthcare community should be really appreciative of the efforts of folks like you, because you already have those relationships, and it's great advocacy for all of us to have. We had a question come in. It involves a little speculation, so heads up. If Biden is elected, what are the first actions related to healthcare we should expect?
Well, I think if Mr. Biden is elected, obviously there's been a huge focus on repealing the Affordable Care Act. I think, along with the presidency, you have to look at, does the Senate switch from Republican to Democrat majority? I think you really have to have those two things happen in tandem in order to stop a lot of the things that the Trump administration had initiated And the ACA is the largest that I think you would see some immediate movement on withdrawing some of the suits that are making their way through the court system. And it would be interesting. I've thought about how would a Biden administration approach, the COVID pandemic differently from, the current administration. I can't see any more restrictive sort of mandates coming from the federal government, but I think what you would see is more of a demonstrative, I guess, a positive display of leadership in terms of wearing a mask, some of the social distancing guidelines, working much more closely with other parts of the administration. Of course, you see tension between the White House and NIAID, where Dr. Fauci is the head. I think you'd see under a Biden administration much more uniformity and cohesion in terms of their policy.
I agree with Rob. I think it's really going to depend on the Senate and if the Democrats are able to take control of that body. I can say what I don't think Biden will deal with if he becomes president, and that's Medicare for all. I think it'll still be an issue, but I don't think he will pursue that. And then, not sure, Biden maybe will require a mask mandate at some point. So I think we'll just have to wait and see.
Yeah, it's interesting to speculate on all that. One of the things I've read up on both parties, and we talked about this earlier, was surprise billing. They both seem to be advocating for a solution to surprise billing. And, when they talk about it at a high level, a lot of times it sounds like it's the provider's fault. And that's a challenge for all of us, is to try to educate the public on exactly how that system works. And I'll be watching to see what solution they come out with. And then I know we have some energy both from TMA, Memphis Medical Society, and probably from the THA as well on the state level around how to address that issue. So I guess stay tuned is the answer to that. Folks,
And
I don't
Clint,
see any more. Yes, Mary.
Oh, I was just going to say, I really thought with Senator Alexander, having legislation that something was going to get done, especially since he was retiring. But it's a difficult issue.
It really is, along with many other things, which is, I guess, a little bit of job security for the two of you, right? As long as things stay complicated, there's going to be a job for you to do. I got one more question that came in. This is a hot topic for physicians. I don't know so much about those working at the hospital level, but there's a big effort out there for mid-level providers to have access or increased access to independent practice in our state. Any thoughts from either of the two of you on that?
Well, I think, shortages of healthcare professionals is something we in the industry are always dealing with. And I note with interest that last week, Belmont University announced that they have intention of starting a medical school in Nashville. So that would be Nashville's third medical school with Vanderbilt and Meharry. So I think that's very interesting to note that move. And certainly at St. Jude, our model is very collaborative in terms of interdisciplinary work. So we use a lot of nurse practitioners, PAs. I think you're going to see, again, with increase in telehealth and remote medicine, you're going to see increased moves to allow these mid-level professionals to provide the service for which they're licensed and certified to do.
Mary, anything you want to add?
No, not at this time.
Okay. It's a hot topic, I understand. We had a real specific St. Jude question come in, Rob, and I think it's a good one. Can you talk at all about how your work's changed with patients who live in other countries because of COVID?
Yeah, so we have a very extensive collaboration internationally through our St. Jude Global program, but that really entails more of us working with professionals in their respective countries and also the government's non-governmental organizations to help increase the survival rate of childhood cancer in those mid-level and underdeveloped countries. In the United States and other developed countries, we've got about an 80% survival rate for all childhood cancers. Unfortunately, in underdeveloped countries, that's just the opposite. It's only 20%. So St. Jude made the commitment several years ago to really expand our global presence, but that doesn't equate really bringing international patients to the United States to be treated. It's much more focused on helping those countries and those healthcare professionals in those countries to increase the level of care in their respective communities so that we can move the needle on those survival rates. So to answer your question, it really hasn't had much of an impact on our admission process for international patients because we already had very, very few coming to this country. Now, what it has had an impact on is the visa process. We get a lot of professionals from overseas, postdocs, grad students, fellows who want to come train at St. Jude, and we're really seeing a challenge with limitations on the J-1B training visas that we typically bring them to Memphis on, and it's not just St. Jude, it's other research academic centers across the country as well. If Mr. Biden is successful in winning the White House, I would anticipate that we would see some easing in those restrictions, which would be a positive for us.
Yeah, that was actually my follow-up question. Knowing a few of the folks over there in HR, I know that's been kind of a hardship for y'all is navigating that through COVID, and Baptist may very well be bringing some international folks in as well. Those are all the questions that I see. Really grateful for y'all's time. I'm going to invite Parker Harris from the MHCE chapter to come in. I think he had a couple of closing comments he wanted to make. Parker, thanks for joining us.
Yeah. Hey, Eric and Andriana, thank you so much for allowing the Mid-South Healthcare executives to participate today. And also thank you to Ms. Freeman and Rob. That was very inspiring and very thought-inducing comments today. It's always a tough subject to talk about legislative issues, especially in a November of an election year. But I think the more knowledge all of us have, the better prepared we are for taking care of our folks. So I did just send out to Andriana a listing of how ACHE members can submit for qualified education credit for today. Also, MGMA members are welcome to submit for the same credit through the American College. It's a very simple 4-step process. So if y'all have any questions on how to submit for that credit, please reach out to me. But Andriana, I'll turn it back over to you, see if you had any closing comments.
Hey, Parker. Yes, thank you all so much. I mean, what a great discussion, just hearing about how policy really affects our patients and our whole healthcare system, how it's really driven by folks who are not even in, who are administering the care. Most times it's by folks who are making the rules. I did receive the email, Parker, and I'll make sure that's sent out. Our members get information through Allison and Clint, so I'll send that guys over to them, and then you all can get credit if you need to. Please be on the lookout for our next meeting. It's in November, and we're going to specifically be talking about mental health during a pandemic. or it could be for yourself, your own mental health, or for your patients. But just definitely want to make sure that we're all taking care of each other, our family members, our coworkers during this extremely tough time. So again, thank you everyone for being here today. Hope you all found this extremely educational and informative. Have a great rest of your day.
Thanks, everybody.
Thank you.
all.